There we go. So I think we're ready to start now. So hi, everyone. My name is Suzanne Float, and I'm a Client Solution Manager at Drofus. And I'm excited to introduce our session today, which will be on the Royal Papsworth Hospital together with our friend at HOK, Robert Gordon. So I'm a Norwegian architect, and I've been a BIM advocate myself since 2013. So just a little bit about Robert. He has such an interesting history. So he works at the HOK London studio, and he has over 25 years of experience, technical experience in commercial, higher education, and healthcare sectors. He's also an expert in Revit, AutoCAD, and Drofus. And he has the role of BIM coordinator for the HOK Healthcare and Science and Technology team. And something interesting about Robert is that he's also the UK's first user of Drofus. So he's also was the technical coordinator on the Royal Papsworth Hospital project, which is why we're excited to have him join us today and talk a little bit more about that project and how they used Drofus. So if you've never heard of Drofus before, it is a Norwegian planning and data management tool developed in Norway. It was developed by Norwegian hospital consultants, and it's been on the market and continually developed for close to 2 decades now. And it's not just for hospital, but for all complex projects. So before hearing a little bit more from Robert, we're going to have a short video with an introduction to what Drofus is. And we just want to say right now, feel free to ask us any questions in the chat during the presentation and share your thoughts, experiences with the Golden Thread, Drofus, and so on. And here is the video now.
Introducing Drofus. Our user-friendly cloud-based software gets information out of people's heads and into a shared location for everyone to see. Drofus is a unique planning, data management and BIM collaboration software purpose-built for the creation and management of building information. Where teams start by capturing the owner's program requirements to establish room needs and functions guiding the building design. Through our ArchiCAD, Revit and IFC integration, we allow teams to validate design requirements against model development in real time. Drofus supports the construction of buildings by allowing teams to share their information in a collaborative platform, ultimately providing building owners with a comprehensive data handover tailored to meet their needs for managing and operating their facilities, allowing teams to focus more time on higher value tasks and less time on the mundane. Less time is spent coordinating the needs of multiple disciplines and sharing the results. Quality checking model design solutions against defined requirements is done in a fraction of the time. With Drofus, teams drastically reduce the amount of time required to create reports. So, whether your project is large or small, simple or complex, Drofus can be your single source of truth, providing a real return on investment from your first project.
All right, great. So now, Robert, we're excited to hear from you.
Okay, thank you very much. Good morning, everyone, and thank you for joining this presentation. And as Suzanne said before, if you have any questions, please feel free to enter them in the chat, and we will address them later on at the end of the presentation. A little bit about myself. I'm a senior associate at HOK, and I've been with HOK for 20 years, the last 15 in healthcare, science and technology, and higher education. Today, I want to share with you my Papworth journey, how we created and managed the NHS database in a BIM environment, starting the project with the correct tools and also the right tool, and developing correct workflows that is robust enough to handle design changes. A little bit about HOK. HOK was founded in 1955. It currently has circa 1,700 staff in 23 offices globally. HOK is one of the largest and most diverse acclaimed architectural design firm in the world. It opened its London office in 1987 where we are now one of the largest healthcare science and technology practices in the UK, with healthcare being one of the firm's largest focus units. We have designed some of UK's most prestigious hospital outpatient care centres. Research including Papworth Hospital, the Royal London Hospital, St. Bartholomew Hospital, the Royal National Orthopaedic Hospital outpatient, and the Francis Crick Institute, which is a lab project. So in developing the process for the database for Papworth, I started off by coming up with a roadmap or a tube map, similar to what you see on a London Underground, where the red line is essentially the business as usual delivery, which is your general arrangement, which goes through the normal cycles of 1 to 500, then reviews, 1 to 200, then reviews, then the final drawn information and the general arrangement at the end. When you do a hospital or higher education or lab or equipment intensive facility, you have to factor in the database, which is the blue line. And this is drawn from the schedule of accommodation that we receive from the client, which we validate, create a room list. We develop templates for the project with dialogue with advisors and clinicians, along with experienced medical planners. And alongside that, we create equipment based on what comes out of the clinical output spec. The equipment work stream, in fact, is a major project in itself, where you have to design, source, and create families, code them in accordance with the NHS standard, and load them into the room. So both the database and the equipment strategy shadows the architectural layouts, and every time we issue any package of information, we have to issue rudimentary room data sheet at the initial stage. As the design develop, we issue fully loaded rooms with room data sheet and loaded and coded equipment. And at the end, we deliver RDS and 1 to 50s along with the general arrangement. In 2010, when we won the Papworth project, HOK was coincidentally switching from AutoCAD as our preferred design tool to Revit. And all our new projects at that time were starting in Revit. We were offered or introduced to Drofus as a natural companion tool for managing our database. We had just at that time finished Royal London and Barts and St. Bartholomew Hospital, and that was like a 200,000 square meter facility with over 10,000 clinical rooms. The Papworth Hospital, conversely, is smaller, but it's a specialist facility. It has over 300 beds, 2,300 rooms, and when you take out the plants, the risers, the stairs, you end up with sort of 1,500 clinical rooms, which we need to produce room data sheets for. So we needed a tool, the tool that was introduced to us, which is Drofus. It was accessible to both clients and designers. It was web-based, online, which meant that you could edit the database wherever you are, if you're in a cafe, at home, at work. Customizable user interface, customizable security. You could give security down to a single line for users so that only the right people change the right information. Customizable reports. Now you could report either equipment, room data sheets, or schedule of accommodation. And we could create multitudes of templates for different variations on the project and apply them as we go. Infinite FF&E room lists, program area, and in an intuitive interface. We could track all the changes so we know when things were added and why they were changed. And it was a collaborative platform. And in the BIM world, obviously, there are other aspects of BIM, such as COBie, IFC, and which, should we wish to use them, we could have. It lends itself to this collaborative working process. So obviously we were coming off the Royal London project with the NHS own form of delivering database and synchronizing. So, and we're working with similar client, Skanska as a contractor, NHS as a client, and we needed to reflect the same level of detail, if not better. So Drofus obviously being the first, using Papworth as the first project in the UK to deliver an NHS facility, needed some settings to be tweaked to make it do what we are used to. So it wasn't what we were accustomed to. Synchronizing is a thing that, the way we do it historically, we would ask the entire team to stop and allow the software to talk to every single equipment and room in the project. That was a big waste, because the time when everybody is out of the project means that nobody is working. So synchronizing was done in a different way. The reports that were baked into the project were not what we were used to. So we had to start dialogue with Drofus to say, could it look like this? And what if we wanted this? And that started a whole series of conversation of what they could change in the baked in reports, as opposed to giving us additional reports. And obviously it's coming to the UK. Not all of the components were translated from Norse to English. So there was that issue. And as I said before, the reports wasn't quite what the trust was used to. Now, that wasn't because we're doing this for the first time. We're using a new platform. We're creating equipment on the fly. We're using a new database interface. We were learning how all of the components work together. So, you could argue that we didn't start with a robust brief. It is a cardiothoracic hospital. The way they work is different, and they had not done this type of hospital before. So it's obvious that maybe a robust brief did not exist at the time. We didn't have an advanced equipment list. Some of the rooms we designed on the fly. You would sit in a workshop and they says, could we have this? We would like this, and we would deliver the equipment to suit that. So advanced equipment list was not available. And then obviously led to the fact that being in a new environment, being a new hospital, being a new way of working, we did not have enough families. And even if we did, you would do a layout and you would go to a trust meeting and they would say, actually, we're not doing this in this facility. So you were loading on the fire. You were creating families that you've never heard of in an environment that you're just getting used to, with new plugins from a software that you've just acquired. And the design itself had not really settled down. So the whole building was still going through design, but we had to get sign off on individual rooms at the same time. So you were designing on a moving platform. So we reached out to the firm. We have over 20 odd offices. They have families. We outsourced. They're clinical outsourced. They're family. They're companies out there that create families for hospitals, and we created families on the fly. So we became expert at creating families. We became expert at stretching and tweaking shapes to match the family that we wanted for that moment. And we acquired through a collaboration. There are specialist rooms with specialist partners that were expert at loading these. And the way the software report obviously was designed for a different sector, and the NHS wanted to see things a different way, and the Drofus developers listened. They came to our office. We talked about what changes we would need. It kind of meant that they probably had to break the software a little bit, because some of the stuff that we're asking for was not the way that software natively work. And they helped us for quite a bit. And then at a certain point, they decided that we should probably do our reports ourselves, use a third-party software called XF Designer, but we won't go into that for this presentation. Now, there is synchronizing is the tool that we use to say, if we load a room and it has 10 chairs, we need to press a button and the 10 chairs will be reflected in the database. In the previous software that we use, you had to, as I said before, you had to come out of the project and the software would talk to every single room or object across the project, which meant that nobody could work at that particular time. What the Drofus offers us is this ability to look at the room, which is the Revit in the Revit column, and the brief, which is the Drofus column, and then say to yourself, well, it says 3 in the graphics and it's got 3 in the database. However, it's got 1 in the graphics and none in the database. The question you're asking yourself, which is correct? Is the brief correct or is Revit correct? And sometimes 1 is correct. So if you go to a design review, it is a graphical experience and the graphics will invariably be correct and you have to come back and update the database. Conversely, the clinicians and the medical planners could have dialogues where they says, we need to delete this trunking, and you delete the trunking from the database. And when you link this room, you will see the instruction, delete that object. Equally, you could add the object. So things had changed, and it meant that we were synchronizing at the room level. And the minute you close this dialogue, that room is synchronized, as to the old method where you did an entire department or an entire floor. This one, as you go through the day, as soon as you finish a room and both columns are reading the same, you click close and the job is done. So we had a slicker interface. We were not held to ransom in that we had to stay out of the project while somebody synchronized the entire project. We could load directly from the brief, as these buttons over here shows, and you couldn't really lie. So Revit has the habit of, it has several ways of hiding things. So things might be on a different work set, a different design option, or somebody's manually hidden stuff. You couldn't really hide that from the Drofus. So in a way, you had a natural QA where it will show an object that you can't physically see because it's been switched off in Revit in some way, and you go, where is that? So that came in quite handy from a QA perspective. And multiple users can actually work rather than, having just one person doing the work. And for us, 6 years ago, these buttons didn't really exist. So the developers were working on this. Now they are there, and now we make full use of these buttons. So we begged, we borrowed, and we modeled everything to the right size based on the cut sheet that's given to us by either the client or clinicians. Because we have to load everything in the project so that we could test clinical functionality. Like you had to test whether a bed could go into a room or whether a wheelchair user can actually get around the space. So in Revit, the layouts are modeled and the rooms are placed with basic parameters such as the room name, the number, and the department. The coordinated plans at this point, whether it's 1 to 200s or 1 to 500, goes for review with the stakeholders. And all rooms are imported and linked to the database in order to create schedule of accommodation, which we then use to validate against the original brief. The layouts, once signed off, we go into loading mode. So we load all equipment and we tag them. And we import the equipment against each room in the database by the synchronizing method that we showed earlier on. This then allows us to create the equipment list and the total room data sheets. Not everything needs to be in the Revit model, and equally not everything needs to be in the database. So for the Revit handles the object and the code and the location, and Drofus will handle things like the room activity, the MEP space, MEP data, which is done by our MEP consultants. We gave them access to the database and they were able to go in and fill in these properties themselves. So we were no longer gatekeeper where they sent us an Excel spreadsheet and we import it. They were actually live design partners in the process. And the finishes is one of the areas where it exists both in the database and graphically in the Revit model. So these cells which says with the code will match the room property in the Revit model. And we can set up the design or the workflow to either take information from a Revit model or push information from Drofus into the Revit model. It is a workflow to match what we're trying to achieve. And and then we can then create these room data sheet with an equipment list, and we can, if we want, add the 1 to 50 image to the package so that you get a complete picture from one piece of paper or 2 pieces of paper in this instance. The design developed by collaboration. We would go to Papworth and we would sit with the clinician and the contractor and the specialist, and we'd talk about, and we'd show them the layouts that we've done, and we would agree, disagree, and come out with a conclusive design. So, because it's different, because it's a specialist hospital, and it's new, the theaters would be different in the layout, and some equipment would not be adequate, and they would like something else different. And this forum is where this argument happened. And this is just illustrating our starting point, how we develop the brief, how we develop a room data sheet, how we go back to the meeting and discuss what we want. We change the design and we come out at the end with an agreed room data sheet and graphics to match. Engagement. Now, the shape of the building, if you've seen the video, it's an elliptical building. So you had to kind of prove the layouts that we're doing were actually proving that the equipment can fit in the space, and that's why it's important that everything is modeled exactly as per the manufacturer. So this scenario here is where we've offered them interactive tablets where they can use different finger gestures to pick up things and move them around the room and see that whether a particular workflow works or not, or a particular configuration works. So this was something that we offered in the early stages. And here is how complicated some of the room spaces are. And we actually replace complicated equipment to test that whether the room would work with or without, or what adjustments we need to make. And this is a RT Zigo unit that we were asked to investigate if it would work. And the test here is to work out whether the equipment could be hung from the ceiling or sat on the floor. I believe in the end, they strengthened both just in case they went for one or the other. So transparency. We gave access to the client and the contractor, read-only access, and we agreed a workflow for them getting comments back to us. And that could be in the form of emails, or because we needed one source of communication. The MEP consultant had total control over the MEP section. They updated that section and in partnership with the medical planning and equipment loading. And we encourage the users not to just go in and says, I don't like this, I'm going to change it. Once the layout is agreed, the changes can only be implemented based on an instruction. So in this particular instance here is an email from one of the design managers saying we should change something in 240 rooms. That could be an expensive piece of equipment, and we would need to know when the instruction happened and why. So this piece of paper would be stored against that change in the database in Drofus for future retrieval. We've also created these one button reports. So we know what the question is, we know what the report needs to say, and we've created these one button reports which says if you wanted to see everything in level 2, if you have Revit access and you are somewhere else, you can click on that PDF report and it generates a PDF for what you're looking to. And this came in handy because the trust was used to creating reports from ADB, and we gave them this opportunity to do one button operation, which actually got them to stop asking for ADB reports. So the RDS is divided up into 5 sections. There is the activities that the medical planners and clinician would tell us that they want. We have the interiors team that would coordinate the finishes, and we have MEP that would input the MEP elements. And then we would load the equipment and create equipment schedule that the contractor can use for procuring. Clinical functionality. So all equipment are modeled correctly. So the correct height, depth, width, and they're placed on the right height. So a socket would not be on the floor. It would be 450 mil off the floor as a starter. And we did mock-ups to prove that they work, which they were, and these were proven to be useful in the development of this room. And we developed standards based on the healthcare own health technical manual and building notes to get compliance. And this got us status A. And this is one of our celebratory drawings when we got our first status A. And we developed rules about what happens around a door, like how far it should be from a wall, where the clock sits, what happens for the light switch, and where the cleaner sockets is. The cleaner sockets, there are over 2,000 on the project. And we developed rules for what happens between doors in the critical care ward. And we developed mounting heights, which shows what height the equipment need to be when it's used in a particular condition. So below a desk, above a workshop, and so forth. And before the mock-up, we had what we call the cave. So this was an invitation to go to Reading University, where one of their science research section had a cave with back projection of our model, and we had to use a headset. So this is 5, 6 years ago, and this is what VR looked like back then. We could visualize the space, and this is what it ended up looking at. But now we've moved on, and we can use a QR code on our Android phone or iPhone and see it from our hands without having to travel all the way to Reading. We created the families and unions to include all the associated equipment, and the reason, and what we're trying to say here is that if a fridge needs a plug, we associate a plug with it. If a phone needs a data point or PowerPoint, we add it to it. The equipment is loaded as you would construct it, and in some cases it may appear that we may be over modeling, but we needed these equipment, and the reality is as you see. And I think we're 5 minutes to go.
We're running out of time now.
Okay. So basically, we created golden rules. We created templates which we apply, repeat, and we created. Let me just go through. We created lots of individual elements which are loaded onto technical equipment. We were able to create wall elevations, we're able to use the equipment in other hospitals, and we're able to load 93,000 pieces of equipment in every room in a virtual model. Thank you. How are we doing?
Thank you, Robert. So unfortunately, I don't think we have any time for questions, but feel free to contact myself and you to ask questions, and we will stick around in the conference space, right?
Okay. All righty.
Well, that sounds good. Well, thank you everyone for joining us, and feel free to reach out and ask any questions, however we may help.
Okay.
All right.
Thank you.
Thank you, Robert.
Thank you, guys.